The emergence of artificial intelligence tools like FaceAge, which analyzes facial features to predict cancer survival outcomes, represents a deeply complex intersection between innovation and risk. While the development appears, on the surface, to be a leap forward in personalized medicine, a closer look reveals troubling ethical and practical concerns that could have wide-ranging consequences for patient care, equity, and trust in medical AI. The premise of the FaceAge algorithm, assessing how old someone looks in comparison to their chronological age, appeals to our fascination with visible aging as a biomarker. But as this technology gains traction, so too must we reckon with the limitations and dangers that come with relying on such surface-level inferences in high-stakes medical decisions. The study, which appeared in Lancet Digital Health, touts FaceAge's ability to outperform clinicians in predicting short-term survival in some cancer patients, boasting a jump from 61% to 80% accuracy when AI-generated analysis was used alongside photos. But this improvement raises immediate red flags about how quickly AI is being positioned as more reliable than human judgment in deeply personal and subjective medical assessments. Cancer prognosis is not merely a statistical problem. It's a human one, layered with psychological, physiological, and social factors that no facial recognition model can fully capture. The notion that an algorithm trained on tens of thousands of photos can meaningfully forecast life expectancy risks, oversimplifying the human condition and detaching patients from the nuances of their care. FaceAge methodology is inherently vulnerable to bias. It was trained on 58,851 images of presumed healthy individuals and later tested on photos of 6,196 cancer patients. Yet there's little clarity about the demographics of these datasets. Ethnicity, socioeconomic status, and medical history, for instance, are all key variables that dramatically influence both facial features and health outcomes. If the majority of the training images came from homogeneous populations, the algorithm may yield less accurate or even harmful predictions for those who fall outside those groups. It's a well-known problem in AI. Biased training data leads to biased results. In healthcare, the consequences can be deadly. A facial analysis algorithm that underestimates the survival odds of patients from underrepresented communities could inadvertently influence treatment decisions or limit access to aggressive care. Equally concerning is the lack of transparency in how FaceAge draws its conclusions. Experts such as Newcastle University's John Bacardit have voiced the urgent need for interpretability in medical AI, asking basic but critical questions. What features of the face are influencing the algorithm's decisions? Are visible signs of fatigue, skin tone, weight distribution, or muscle loss being misinterpreted as signs of advanced biological aging? Without knowing how the AI interprets data, clinicians may over-rely on its output while ignoring the possibility of confounding variables. In medical contexts, where lives are on the line, this black box approach is unacceptable. If practitioners cannot explain to patients why a system predicted a shorter survival time, the foundation of informed consent is undermined. Moreover, the psychological impact of AI-derived survival predictions cannot be overstated. Cancer patients already live under a heavy cloud of uncertainty and fear. Introducing a system that estimates their biological age based on their appearance and correlates that with survival odds could cause unnecessary emotional harm. How would a patient react to being told that they look older than they are and that this is an indicator of worse outcomes? Such information, even if statistically relevant, must be handled with extreme sensitivity, something that current AI models are wholly unequipped to provide. The reduction of a person's prognosis to an algorithmic judgment based on their face risks not only dehumanizing the patient, but also diminishing the role of holistic clinical care. The face, after all, is not a neutral data point. It's a highly personal, culturally charged canvas. Using it as a diagnostic tool opens the door to a range of ethical dilemmas. If insurers, for example, gain access to FaceAge outputs or similar tools, could they begin to deny coverage or adjust premiums based on a patient's perceived biological age? Could employers use such tools under the guise of wellness monitoring? The potential for misuse is staggering, especially in a healthcare ecosystem already rife with inequality and data privacy concerns. Even if we assume the best intentions from researchers, the push to deploy FaceAge and similar AI models reflects a broader and more troubling trend. The techno-optimistic belief that more data and more machine learning inevitably lead to better outcomes. This is not always the case. Without a full understanding of the limitations of the data, the mechanisms of prediction, and the lived realities of patients, we risk embedding systemic flaws into clinical decision-making. Worse, by relying on superficial signals like facial appearance, we risk replacing comprehensive medical evaluation with statistical shortcuts that may be appealing in their efficiency but dangerous in their consequences. In the end, FaceAge may offer intriguing insights into the biology of aging, but it is not a crystal ball. It is a tool, one that must be wielded with extreme caution, transparency, and rigorous oversight. Until the biases are thoroughly addressed, the interpretability improved, and the ethical boundaries clearly drawn, tools like FaceAge should not be seen as solutions to complex medical questions, but rather as experimental technologies that remain, for now, closer to risk than remedy.